Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for March 20th, 2024. Thank you for joining us this month. National Athletic Training Month is held every March in order to spread awareness about the important work of athletic trainers. We are especially thrilled to have our presenter, Shelby Baez, with us today because she is an athletic trainer herself. She is also an assistant professor in the Department of Exercise and Sports Science and the director of the Psychology of Sport Injury Laboratory at the University of North Carolina at Chapel Hill. Dr. Baez is a certified and licensed athletic trainer with expertise in the psychology of sport injury. Dr. Baez's research examines the impact of psychosocial factors on biological outcomes, such as biomechanical alterations and secondary injury risk in patients after sport-related injuries. Her lab also seeks to identify clinically feasible, novel, and technologically driven psychosocial interventions to improve health outcomes. These techniques range from in vivo and augmented reality graded exposure therapies to virtual reality and mobile delivered mindfulness meditation. Dr. Baez has been funded by the National Institutes of Health and other regional and national foundations to support her work. She was the recipient of the Association for Applied Sports Psychology Doctoral Dissertation Award in 2020, the recipient of the American College of Sports Medicine New Investigator Award in 2023, and the recipient of the National Athletic Trainers Association Research and Education Foundation Dr. Freddie and Mrs. Hilda Peng Fu New Investigator Award in 2024. The title of today's presentation is Psychologically Informed Practice to Enhance Health Outcomes After Sport-Related Injury. Welcome, Dr. Baez.
Well, thank you so much for that warm welcome. And thank you so much all again for this invite to join the Lunch and Learn webinar. So as mentioned, I'm Shelby Baez, and I'll be presenting on this idea of psychologically informed practice and how we can use this to enhance outcomes after sport-related injury. And I have no conflicts of interest to disclose, but again, want to give another shout out to my athletic trainers for National Athletic Training Month. For today's webinar, I have three goals in mind. The first goal is to provide you all an understanding of the consequences of maladaptive psychological responses after sport injury. I want to discuss this concept of psychologically informed practice. And then I want to discuss how we've been integrating graded exposure and mindfulness meditation into some of our research in the lab, but also provide some hopefully tangible take-home points for how this can be implemented into clinical practice as well. When we think about the goals for successful recovery after sport-related injury, there are a couple of different things that come to mind. The first goal is really looking at trying to return the patient to optimal physical as well as optimal psychological function. We want patients to be able to go back to desired levels of sport or desired levels of physical activity. We want to reduce the risk of sustaining subsequent re-injury or injury to a contralateral limb. And then we also want to minimize the risk of the development of chronic disease. And I'm going to preface this as a lot of my work is primarily in this ACL injured population, but we see this also in other patient populations as well. So this isn't just an ACL problem, and I'll try and echo that throughout the presentation. But when we look in the literature, we're seeing that patients aren't going back to sport or engaging in desired levels of physical activity. We see that in certain patients who do go back to sport, that they seem to be at increased risk of sustaining re-injuries to their ipsilateral limb or to their contralateral limb. And then we also see that these patients are also at risk for development of osteoarthritis and chronic disease down the road. So when we look at the literature and the scope of sport-related injury outcomes, we aren't really meeting the mark for where we want to be at from a goal perspective. And a lot of my work is really getting at, are we actually really returning patients not only to optimal physical function, but also optimal psychological function? And one theoretical model that really was the premise for a lot of the work that I do is the fear avoidance model. And what this model suggests is that when you have an injury experience and you experience pain, you may go into one or two pathways. You may have lower levels of fear. You're able to confront the injury and the recovery or in the rehabilitation and have what I'll term as an adaptive recovery. However, patients may also go into the left side of this fear avoidance model, where we see patients may start to engage in catastrophizing behaviors, so magnifying that painful experience or that injury experience, feeling helpless about it and potentially constantly ruminating about their pain or their injury experience, which can then develop fear of pain, fear of re-injury, pain-related anxiety that can then lead to avoidance behaviors, such as avoiding things like physical activity. And then, unfortunately, a cycle of disuse, disability, depression that can lead to more painful experience. So our goal with what we want to do with a lot of our work is to try and get patients to be on this right side of the fear avoidance model rather than going into the left side of this model. And what are we actually seeing as it relates to the literature? Do we see support for this model in the sport-related injury population? And the answer is yes. When we look at factors like psychological response or psychological readiness to injury, or things like fear, we see that these have been associated with failure to return to sport, failure to engage in physical activity, as well as increased secondary injury risk. Again, those big tenets of our goals for successful recovery after sport-related injury, we're seeing that these psychological responses are impacting those patients in that area. And as we think about potentially some of the underlying mechanisms for these bigger goals, we see that things like fear and decreased psychological readiness have been associated with aberrant jump landing biomechanics, emotion-related neuroplasticity, as well as slower lower extremity response time. And as we get into the scope of thinking about more of an osteoarthritis population and potentially knee symptoms, some of the work we've done from an ACL perspective has identified that individuals who have worse psychological readiness and higher levels of injury-related fear exhibit persistent knee symptoms after ACL reconstruction. So I have the privilege to be part of an Osteoarthritis Action Alliance consensus statement on preventing osteoarthritis after ACL injury. And we developed 16 different recommendations ranging in areas of patient resources and education to comprehensive rehabilitation programs and physical activity participation. But we also had recommendations specifically to the psychology and psychological interventions from a knee-OA prevention standpoint. And these included things like psychological skills training, graded exposure therapy, and then potentially the integration of cognitive behavioral counseling. Now, when we look at the consensus here, we can see the support in the final round for these were relatively lower. And then the one consensus that didn't meet, one recommendation that didn't meet consensus was the cognitive behavioral counseling one. And I think this brings up a couple of different concepts in this particular space. Is one that we recognize that these psychological responses matter when we're thinking about the overall scope of meeting those goals for sport injury recovery. But we also recognize that there's some significant concerns about the evidence in this space. And Garrett Bullock published an Austin systematic review of meta-analysis that really led to a call for a need for high quality observational and intervention studies in this space. And the hope is that if we can continue to develop these high quality research projects, that eventually, if we were to redo this consensus statement, hopefully we would have more consensus for this space. So what do we do about it? And that is where we're really pushing this idea of engaging in both psychologically informed practice, but also psychologically informed research projects. So I have the privilege of working with Dr. Kate Jocumsen to develop a application for psychologically informed practice in a sport-related injury population. But this idea was really developed for patients with chronic pain. So Chris Main and Stephen George pushed this idea of psychologically informed practice, which is the incorporation of this patient's beliefs, attitudes, and emotional responses into patient management based on biopsychosocial models. It's not asking rehab specialists and providers to become psychologists or vice versa. This is simply the balance between what we're doing on the day-to-day from a physical rehabilitation and musculoskeletal or concussion rehabilitation standpoint, but while also considering the role of psychological factors and how some of the things we're already doing in our practice can be slightly tailored to address potentially some of those psychosocial concerns. The QR code here is to the article that Dr. Jocumsen and I did together that really outlines this concept of psychologically informed practice more, as well as we'll go into depth about the different treatments I'm going to talk about more on the next slide. So I think it's a great resource if you're really interested in this concept as it relates to sport-related injury. What I really love about psychologically informed practice is looking at the clinical endpoints here. We can see that the clinical endpoints are decreasing pain, decreasing disability, improving physical function, improving return to sport, and also improving physical activity. These are the same goals when we think about traditional musculoskeletal rehabilitation after sport-related injury. These are the same clinical endpoints. However, our approach from psychologically informed practice will include different psychological targets. So I included things like fear and decreased self-efficacy and pain catastrophizing here. It's just a couple of different examples of those psychological targets. And the treatments here could be pairing some of the things we're already doing in our rehabilitation with the integration of techniques like diaphragmatic breathing and progressive muscle relaxation. When I talk to a lot of athletic trainers, especially about implementing these techniques, I always challenge them to say, you're probably doing some sort of diaphragmatic breathing in your practice, and you don't even recognize it when thinking about handling acute injuries. An athlete will go down on the field and they're hyperventilating. And one of the things that we do is just tell them to take a deep breath in through their nose and out through their mouth. And we're at that point already engaging in a psychologically informed practice. Other techniques can be more mindfulness techniques from an acceptance and commitment therapy lens, using open monitoring, focused attention, mindfulness strategies. Behavioral techniques like graded exposure and graded activity, as well as cognitive restructuring techniques like positive self-talk and thought-stopping behaviors. And for the sake of time, I'm not going to go into depth about each of these. Again, that resource on the previous page, and I'll pull up that QR code again later down the road, discusses each of these a bit more in depth. So where do we begin? And I always recommend beginning at measuring the different types of psychological constructs that you're interested in and using patient-reported outcomes in your practice. PROs are great because they get information directly about the status of the patient's health directly from the patient. From a clinical practice standpoint, these are great to see. Is your intervention actually changing over time when you're working with these patients? And from a research standpoint, we can use these questionnaires to really get information about effectiveness of some of our clinical trials. So in a clinical trial I'll talk about later, we're using these PROs to help to see, can we actually decrease fear after injury? And despite some of my best efforts as part of a research project in graduate school, we tried to improve the agreement between patient-reported outcomes and performance-based outcomes. And quite frankly, we didn't. And it's because PROs are measuring a different aspect of health than we're getting with performance-based outcomes. And the goal is to try and get these to align, but recognizing that if there's a discrepancy, that it could be something related to decreased confidence or a psychosocial response. Now, a couple of recommendations when we're thinking about PROs. The thing that I always recommend for providers is to use these to really help to facilitate patient communication. These will have scores on them, and cutoff scores will often be developed. But I always will recommend providers to not use the cutoff scores when trying to make the treatment decisions for psychosocial impairments. There isn't really much difference between a cutoff score of a 17 versus an 18 on a kinesiophobia questionnaire. The patient's still exhibiting some sort of symptoms, and it's helpful to be able to use that to facilitate conversation. In research, we use cutoff scores just to try and make something that is innately gray into something that's black and white, and it can be helpful there. But from a clinical practice standpoint, it's a bit more challenging. And we recommend always using these when you're screening patients with major clinical time points. So if you're going to do a HOP testing or strength assessment, throw in a PRO as well to get some information about their psychological status. And then screen all individuals if you're suspecting the patient struggling with a poor psychological health, and we recommend prior to return to sport. And I'm not going to talk about motivational interviewing in depth today, but this is a strategy that you can learn a bit more about that can help to facilitate developing rapport between the patient and the provider, especially with some of these challenging topics when we're talking about psychological responses to injury. So I definitely encourage you all to look a little bit more into motivational interviewing. And some example patient-reported outcomes that we can see used quite frequently is even something as simple as a 0 to 10 scale on how much pain you have. That would be an example of a PRO. And we also can see more specific recommendations, such as using a Tampa scale kinesiophobia to measure fear of movement or fear of re-injury, the pain catastrophizing scale to get at some of that pain catastrophizing concerns. And then there's also injury-specific psychological readiness questionnaires, including the ACL return to sport after injury scale, as well as the ankle ligament reconstruction return to sport after injury scale. And we talk a little bit more about this in the QR code here in this paper. Now, can we actually do anything about it? And the answer is yes. Rehabilitation specialists can effectively implement psychological skills trainings and psychoeducation. And when speaking specifically from an athletic training lens, these are within the scope of our competencies that we should feel confident in assessing, but also intervening from a psychological skills standpoint. And the goal of what we're trying to do here is ultimately adjust the patient's perception, because perception is reality. If they're perceiving something to be fearful, if they're perceiving something to be painful, then we have to be respectful of that reality, of that patient's perception, and that's the reality. And a lot of the goal is what we're doing here with some of our specific interventions is to try to adjust the patient's perception so we can adjust the reality. Now, the other big problem that we have to address and acknowledge when we're thinking about info in this space is that while rehab specialists are great at acknowledging and identifying these psychosocial responses, they feel less prepared to actually intervene and address some of these psychological skills and implement some of these psychological skills in practice. We can probably talk for a long time about why this is the case, but some of the work that we specifically do in my lab is trying to reduce these barriers by one, implementing different techniques that we're already doing in clinical practice on the day-to-day, but slightly shifting the focus. And then two, using technology to our advantage to implement some of these skills in order to help to improve our outcomes. So one of the ways that we first started exploring engaging in cognitive behavioral and psychological skills training is through implementing graded exposure therapy. So unlike Professor Gallagher, who's addressing his fear of heights and snakes and dark all at the same time, the key here is a progressive exposure and gradually exposing things to what the patient's afraid of. And in this case, what a lot of patients may be afraid of are certain movement strategies. And from a rehabilitation standpoint, we are fantastic at gradually exposing and gradually progressing patients through movement. So this makes graded exposure a great tool for rehabilitation specialists to integrate. So instead of using pain or soreness as the progressive factor, you can use things like fear and anxiety to help you progress someone through a specific fear of movement. So you work with the patient to develop a hierarchy of fearful situations, and then you start with the least fearful task and then work your way up to the most fearful task to eventually address, hopefully, their fear of movements. And we just did this as a pilot study with 6 patients. We had them complete 5 weeks of graded exposure with tackling 3 specific tasks over the course of the 5-week period. So one of the spoilers before I orient you to this figure is that we saw that graded exposure was great at reducing fear for a specific functional task, but not necessarily the overall general phobic responses as measured by questionnaires like the Tampa scale kinesiophobia. So to orient you to this figure here, we have the 3 tasks that we address in the red boxes. So landing after a jump, lateral lunging, and pivoting. And this was just for an example of one of the participants. Blue represents the pre-exposure therapy, and the green represents the post-exposure therapy. And when you look at the 3 that we addressed, we see a pretty significant change in their fear levels, with higher levels of fear representing higher scores representing higher levels of fear here. And we can see this translate into some other areas too, sliding, sudden deceleration, and starting a sprint as well. However, we got really curious as how can we start to potentially get at some of those general phobic responses? And this is where this idea of potentially pulling out a tenet of acceptance and commitment therapy came into mind. And what acceptance and commitment therapy on a very broad scoping level is emphasizing acceptance for handling negative thoughts and feelings. So instead of trying to eliminate these unpleasant experiences, is learning how to handle these unpleasant experiences when they come into our life and really improving that psychological flexibility. So here with acceptance, we can see instead of ruminating that it's raining, that it's so annoying, I hate the rain, my day is ruined, or potentially ruminating about that stressful athletic situation that they may face, they just acknowledge that it's raining, or they acknowledge this is just stressful, and they're able to continue to move forward. And one way that we're channeling it is through really focusing on this tenet of being present. And one way that you can work on being present is through this idea of integrating mindfulness. So mindfulness is the basic human ability to be fully present, aware of what's happening, but not overly reactive. And it's a quieting of our thoughts that can be cultivated through meditation. Mindfulness is great because we've seen that it can lead to decreases in fear and anxiety in traumatic knee populations. And then when we think about a knee OA population, we see that those individuals who have higher levels of state mindfulness, we see it helps to, it's associated with psychological health, as well as moderating pain in a knee OA population. And then some of the work that we also wanted to do was to explore, can we actually start to move the needle on some of the phobic responses in just a small cohort of patients after ACL reconstruction. So we used the Headspace application, and they completed 4 weeks of mindfulness meditation, 3 sessions a week for 12 total sessions. Now, to preface this, we didn't enroll these patients based off of their fear levels. So they just had history of ACL reconstruction, and we gave them Headspace. So to orient you to this figure here, blue would represent the group that would be considered to have high fear at baseline, and then orange would represent the group that has low fear at baseline. The darker colors represent the pre-mindfulness meditation, and the lighter colors represent the post-mindfulness meditation. So when we look at the high fear group, we're seeing the needle moving in the right direction there, which is great. But when we look at the low fear group, we see potentially some increases there that in other psychological intervention studies that intervened on those who had lower levels of fear also exhibited some increases in psychological distress and in increased fear, suggesting that one, make sure you take the time to measure where someone is at from a psychological status standpoint, and two, making sure that you're not intervening on someone who may not need the intervention. And there are a lot of different tools and techniques out there, including Headspace and Calm. Virtual Hope Box is a free app that can allow you to do some diaphragmatic breathing from a focused attention standpoint. That is a free app, and I think it's really cool. And then lastly, we're also implementing mindfulness meditation in our group using virtual reality as a technology plug-and-play solution to see if VR mindfulness meditation can help to decrease fear, improve reaction time, and then alter brain activity in patients after ACL reconstruction. So patients are randomized into a VR mindfulness meditation group with a neuromuscular training rehab, or to a VR sham and neuromuscular training rehab. And as we're thinking about the outcomes here, we're seeing decreases in fear, improvements in knee symptoms and knee pain, and just this case study of one patient who piloted this 8-week VR mindfulness meditation study. And then lastly, I want to end with this idea is knowing what you know and knowing what you don't know, making sure that you take the time to refer out when things are out of the scope of your clinical practice. But the big take home point from this slide is that after the referral, that's not when it stops. It's making sure you follow up and communicate with the patient and continuing to provide social support for that patient. So some final thoughts here is, again, perception is reality. And a lot of what we're trying to do here is to try and shift that patient's perception so we can adjust the reality. And it's important to be patient. These techniques take time for you and take time for the provider. And graded exposure and mindfulness are just a few of the techniques that can be used to assist to help with patient care. And when in doubt, be conservative. And then that's just a link to my website, and always happy to help to answer any questions. And then, of course, I need to thank my lab group, because none of the work that I talk about today can be completed without their help. And then I'm happy to answer any questions you may have.
Thank you so much, Dr. Baez, for that great presentation. It's so important to think about the psychosocial aspects of sport-related injuries and rehab. So we'll open it up to questions from the audience. Feel free to type any questions you have for Dr. Baez into the chat, and I will read them aloud. One thing that popped up for me, just out of curiosity, Dr. Baez, with the mindfulness meditation studies, obviously it's pretty clear, I would assume, to the athletes that they're doing kind of an intentional intervention to address some of the psychological aspects of recovery. But day to day, how upfront are you with athletes about the psychosocial approach to rehab, or is it just something that rehab specialists incorporate into their practice?
I think it's one of those things where we should be a bit more upfront with discussing that, hey, on this particular questionnaire, you said that you are extremely fearful to move to the right or move to the left or cut or jump. I think it's one of those things where just like we would talk to our patients about improving their quad strength, this would be something that we should also talk about with our patients on, okay, we're going to do some techniques to try and also help you from a psychosocial standpoint. And I think that helps to normalize and reduce some of the stigma when we're thinking about addressing mental health and addressing psychological responses in rehabilitation by allowing them to know that we're doing this to try and help to improve both psychological responses, but also physiological responses too.
And probably helping normalize some of those fears or some of those negative responses they're having to the recovery.
Definitely. That's one of the things I always recommend providers doing when, especially with fear, is normalizing the fear and letting people know that fear itself is designed to serve as a protective mechanism. And when you're engaging in a task that potentially led to a previous injury, that this is normal. But when fear starts to occur in the absence of an innate threat, that can be detrimental. So we want to balance whether the fear is protective or whether the fear is actually potentially maladaptive. And that requires using these PROs to measure, but also having communication with the patient. And then also having a clear idea where the patient is at functionally. If they have really, really poor strength and really poor movement patterns, they probably should have a little bit of fear. But if they have really great strength and they move really well and they're really functional and they still have fear, that really should indicate that a psychosocial intervention is probably needed for that patient.
Right. So kind of helping tease out when is fear good and when does it need to be addressed?
Yes, exactly.
Yes. Well, I don't see any other questions here from the audience. Do you have any final words before I tee up next month's presentation, Dr. Baez?
No, just thank you all so much again for having me, and feel free to reach out if you ever have any questions about this in this space or any desire to collaborate on some research in this space if you're a researcher on the call.
It looks like maybe we have a question coming in, so we'll hang on just a second while the participant's typing. In the meantime, I'll go ahead and let everyone know that our April 17th Lunch and Learn is titled Using the Social Identity Model of Identity Change to Explore Social Role Participation in Identity Among U.S. Adults with Osteoarthritis. And that will be featuring Stephanie Rosado. So stay tuned for registration details on that. And if you'll type your question into the chat, that would be great. Thank you. And while we're waiting for that to come in, I will populate the poll if everyone would take a minute to answer those questions before they leave. That would be great. All right, Dr. Baez, here's the question. Would you recommend the TSK11 or FABQ for baseline data on ACLR patients for research purposes?
That's a great question. We've been using, I see the TSK11 more and more just because of the associations with movement. But I think it gets at to what your research question is. Are you more concerned about fear of movement and fear of re-injury or fear avoidance beliefs? Because those are two separate types of fear constructs that may impact the patient differently. So I think when we're getting into considering injury-related fear and trying to identify a question is what type of fear that you're trying to get at. If you're more concerned about fear of movement, I would probably use the TSK11 over the FABQ.
Great. Thank you. Thank you, Dr. Baez. Thank you so much for your time and for sharing your expertise with us in our presentation today. And that concludes our webinar. Thank you all for joining, and stay tuned. You'll get an email later this week with a link to the recording, as well as information about registering for future Lunch and Learns. Thank you all and have a great day.